So it's really key that PHM becomes everyone's problem, that everyone has a role to play in PHM. We don't really want it as a standalone project. We want it to be something that is embedded in core business as usual activities. The greatest impact is about not necessarily just delivering one or two high impact projects, but actually it's about embedding PHM through everything that we do and about making PHM kind of core business as usual.
So participants that have engaged with the PHM training programme have self-reported and improved confidence in understanding of what population health management is, how to navigate the self-serve Optum Pathfinder dashboards, and also an improved confidence in how they would go about evaluating some of the projects and programmes that they are implementing. We currently have 45 projects that are being worked on that apply population health management techniques, and that might be a variety in different ways in which we apply those techniques.
So the project we're talking about is the CSU Health Project. That links to hypertension, which is one of our key priorities at the ICB and for the NHS as a whole. We did a bit of a market test on health stations, and CSU came out top on a competitive analysis. They do health checks for people, which is a 4-minute health check. They do your BMI, your blood pressure, your body fat, and then they give you a calculation at the end and give you some next steps. We had 17 stations that we rolled out from May last year, and I think we did about 12,000 health checks over the course of the year, which is really impactful to our population. The health stations themselves are self-service, so you don't need an appointment and you don't need supervision to do them. Feedback's always really important for any project, and co-production's a really big element of anything we try to do at the ICB. We had a real good case study from the Be Well bus.
The Be Well bus is a mobile health resource that we have and that can deliver education and intervention within the Ipswich and East Suffolk Alliance. The outcome of the project with regards to the CSU is across the Ipswich and East Suffolk Alliance over 12,000 health checks have been delivered. I was quite keen to highlight specifically the CSU machine that's been on the Be Well bus since May of 2024. From May 2024 to the end of June of 2025, there's been 1,187 CSU health checks delivered, 1,115 of those to unique participants. It's been a massive incentive to get people to come onto the bus in, again, in a non-clinical environment and raise more awareness and education about blood pressure, not just to have an immediate check, but actually then to have follow-on checks more frequently.
The great thing about this project is it cuts off so many different priorities that we have, including early intervention, community focus, keeping people out of emergency situations and out of our acute settings, and also keep some people away from primary care, which is under a lot of stress, of course.
The starting point for this project was the development of our segmentation model for the SNE population. Our segmentation model basically took our population of 1.1 million and looked at how people can be divided into different cohorts. Healthcare need is quite unevenly distributed, and as you'd expect, there are certain populations, such as the elderly population, where need is much greater. From analysis of that model, what we were able to find is that there's around about kind of 12 long-term conditions which are driving most of the observations of people moving from poor into poorer health. And of those conditions, the majority are around cardiovascular disease, or kind of linked to cardiovascular disease. That then led us kind of working on how do we start to think about how we mitigate demand for healthcare services in future.
We established a multidisciplinary task and finish group. We ensured that we had clinical representation. We ensured that we had CVD commissioners involved in those conversations. We horizon scanned for high impact interventions. We horizon scanned for new and pipeline innovations. What we were able to do by working in collaboration with our system partners was develop a set of 11 clear recommendations that we would be able to take forward in collaboration with the integrated care system.
A key outcome of starting from what Charlotte's alluded to is having the ICS engagement from the start, and we need their buy-in to get anything rolled out. We've done similar things such as a big communications plan, doing some scoping around innovations that can support how we take the priorities forwards.
We used the data to identify those key condition areas that were driving the most significant demand risk. By really having that clear data kind of picture, we were able to really target who needs to be a part of identifying what the challenge is and kind of how we take that forward together.
We've, through this project, been able to very clearly articulate a kind of what our problem statement is around kind of cardiovascular disease. I think it's also been a nice example of just working differently. Very evidence-led from the very start with kind of analysts in the first instant, but then bringing in the kind of project management, bringing in the clinical leadership. It's a great foundation from which we can do more upon, I think, going forward.
We commissioned a campaign called the 12th Man. 12th Man are a local charity who will go into businesses, training them up on mental health first aid. We targeted businesses that were tattoo shops, pubs, sports clubs, gyms, because these are areas where there is a high chance of engagement within the male cohort that we were looking to target.
We were able to use the population health management data with its ability to link individual data sets up for that person level data. Because it's linked and because it's at person level, you can really look at where the inequalities are.
As a result of this project, we were able to train up 37 individuals in mental health first aid training. We improved mental health literacy within the community. We improved peer-to-peer support that businesses and community organisations can provide to their customers. We spoke to a local boxing gym which had completed the training. The owner had mentioned that because of the position he and his coaches hold within that community, they are in a position where people open up about the challenges they face in life. What he said was one of the biggest and most recurring challenges that people open up about are their mental health challenges. As a result of the training, him and his coaches are able to better tackle these conversations, to support people and to be able to support them to plug into a wider community and help support them to mitigate any issues at an earlier intervention.
It's also sparked further conversations with our mental health leads as to where we should be focusing certain resources. As we're going through with more data coming in, we get to have that in-depth look into where we can actually target these individuals. Following on from doing the work with the men's mental health, we were able to expand the project to look at persons as well. And I think that's one of the strongest points about PHM data is that we can follow people longitudinally and look at what their history was within the healthcare system and perhaps identify chances where we could intervene at an earlier point.
The thing I think that I am most proud of in our work with public health probably doesn't come down to a specific service or a specific project, but I think it's the way that we work as a system in a collaborative way.
It's fundamental to the success of a PHM programme in any integrated care system